So welcome to our program today. Our program is Marching Toward Equity, Addressing the Social Determinants of Health and Wealth program. And this is being put on by the Central Illinois chapter of the Links Incorporated. I am your moderator today. I am Dr. Jocelyn McClain Hazelwood, and I am a native of Washington, D.C. I currently serve as the Vice President of the Central Illinois chapter of the Links Incorporated. I received my Bachelor of Science degree from Brown University and my Doctorate of Medicine from Howard University College of Medicine. And I am a board certified anesthesiologist. It is my pleasure today to welcome our panel. It is a distinguished panel, and they are more than qualified to address the issues that we plan on learning about today. I'm excited to hear their thoughts and, of course, their experiences with everything that's involved. So Dr. Takeisha Davis is a public health physician and a healthcare administrator. A Louisiana native, she's a graduate of Xavier University, Johns Hopkins University School of Medicine, where she earned a doctorate of medicine. She completed her pediatric residency at the Children's Medical Center in Dallas, Texas. She holds a master in public health from the Harvard School of Public Health. Through extensive work experience, Dr. Davis is committed to reducing disparities in health outcomes and promoting health equity by focusing on evidence-based clinical and population health initiatives, and she's been doing this for decades. She is also a member of multiple organizations, and for today, I'll highlight she's a member of the Links Incorporated. She is a past president of the Louisiana Public Health Association. Dr. Davis's greatest joy comes from raising her son, Wayman Davis Jr. Welcome, Doctor.
Thank you so much.
Dr. Chinelo Echeazu is a physician specializing in obstetrics and gynecology. She is a native of Chicago and earned a Bachelor of Science degree in bioengineering from the University of Illinois at Urbana-Champaign. She has also obtained a post-baccalaureate certificate and medical degree from Southern Illinois University School of Medicine. She completed her residency at the University of Illinois College of Medicine at Peoria. She is a board certified and OBGYN through the American Board of Obstetrics and Gynecology. She's also a fellow of the American College of Obstetrics and Gynecology, and she has special interest in minimally invasive surgery. She is an active member of Alpha Kappa Alpha Sorority Incorporated. She lives in Springfield, Illinois area with her husband, 2 children, and 2 dogs. Welcome.
Thank you.
Jerel Watson MD is a physician specializing in emergency medicine. He is a native of Chicago and earned a Bachelor of Science degree in biology with a minor in psychology from St. Xavier University. He obtained a post-baccalaureate certificate and his medical degree from Southern Illinois University School of Medicine. He also completed his residency at SIU. Dr. Watson is board certified through the American Board of Emergency Medicine. He enjoys working out, participating in, and watching sports. He lives in the Springfield area with his wife, who's by his side, 2 children, and 2 dogs. Thank you all.
Thank you. Thank you.
So our discussion today is going to focus on the social determinants of health. And there are 2 areas that very well exhibit the healthcare disparities that exist in our society. So the first we're going to discuss is maternal and infant mortality. And our panelists will talk more about it, but the statistics are astounding. The maternal mortality is 3 to 4 times that of the white population. And the infant mortality, again, is about double. Now, if my statistics are wrong, I'm sure my panelists will correct me. So I'm going to start with Dr. Chinelo. What has been your experience in caring for African-American pregnant women and helping them navigate some of the challenges of the social determinants of health?
I think that's been a very interesting part of my practice because I live and work in Central Illinois. And so this is an area that, you know, Black women are a minority here. And so I would say that there aren't as many resources or, you know, physicians of color for them to even reach out to. One thing that I have had is that many women in the community, once they found out that I was around, specifically searched me out because they knew they wanted to see a physician that looked like them. And I think just having that experience of also being a Black woman, they trust that I can relate to some of the issues that they are dealing with, or will acknowledge those issues and not kind of brush them under the rug, you can say. I've had patients from all walks of life. I've had women that are very poor, don't have a lot of resources, don't have transportation, don't have the funds or finances to even, you know, get medication that they need, to taking care of patients that are, you know, very well financially or very educated. But either way, that statistic that you gave, it's the same for any Black woman, regardless of your background. It doesn't matter your education, lifestyle. If you're a Black woman, you do have a higher risk of dying during anything that's pregnancy related. And so I think being aware of that statistic and having that passion to want to care about women that look like me helps me do my job the way that I should, which is to be available to make them aware of resources that they may not know of, bringing awareness to certain conditions, symptoms, and things that other people might not talk to them about. And so, I mean, that's really kind of my experience has been really educating a lot, because a lot of women that I've taken care of have not been exposed to a lot of the things that I've talked to them about. No one has ever spoken to them about them before. And so that's probably a key part of taking care of patients, has been educating them as best as I can.
Do you feel racism, institutional racism, has an impact on the effects that you've seen?
Absolutely. And that would not just be in my little bubble of Central Illinois. That's a nationwide problem. As networking with other physicians across the country, other Black OBs, we all can talk about examples and situations where we've seen our non-Black counterparts treat patients differently. And so it's definitely an issue. I don't think it's something that can be fixed easily or quickly, but it's going to take work on a lot of different, you know, a lot of different organizational parts of the health system to be able to make that change. But I think as a patient, the biggest thing that you can probably do for yourself is to advocate for yourself. A lot of times, some Black women are just ignored. And if you don't speak up for yourself or try to, you know, advocate, I mean, the outcome might not be what you would want it to be. And it's unfortunate that we have to do that. But I mean, that's kind of the society and the environment that we're in right now.
So you mentioned advocate for yourself, and you mentioned the system. Dr. Davis, you have quite a bit of experience from an administrative perspective. What can be done from that angle to improve some of the things that we're talking about? You're on mute.
On mute. There's a lot that can be done and that we should be doing as healthcare systems. So I've been serving as the CEO of New Orleans East Hospital, which is a small community hospital, a part of a 6-hospital system that includes everything from freestanding children's hospitals to our level 1 trauma center in New Orleans. And what our hospitals have in common is that we take care of a predominantly Medicaid population, which we all know with respect to the communities we serve, that means that they're socioeconomically challenged. Depending on where you live, it's a highly minority community, which is the community I serve, 85% African American, another 11% Vietnamese American. So in healthcare systems where the majority of your patients have been marginalized, disenfranchised, in just about every aspect of their lives, it's tough for them to advocate for themselves because they have what we call a compound disadvantage, right? They have not received the educational resources that they should have. They have not received the access to living wage paying jobs that they should have, which then leads them to living in communities that are under-resourced. So they live in food deserts. They don't have opportunity to have well-built communities with space for safe physical activity. A lot of times there are toxins in their communities. They may live in communities that are around plants that emit environmental toxins. And so you have this compound disadvantage that the patients we serve are living in. And the last thing that they tend to think about is their health. So we tend to, at our system, say that we need to change the paradigm from outside of the 4 walls of the hospital, right? We were all trained to take care of patients one by one, make sure that we're getting the best outcome for our patients. We're now starting to, within the context of traditional medicine, look at our patients as a part of communities or cohorts. Surprise, surprise, we don't all have or live individually and without any impacts from our communities, right? So as hospital systems, the way that we begin to tackle that is to, one, acknowledge that we have done a disservice and there is systematic racism, everything from the way in which patients get access to our systems or have lack of access to not having access to quality treatments, medical care, that they have the same types of groundbreaking treatments that might be across town. And then saying we're going to put our resources into community-based efforts, things that will help to uplift the built community, like helping to have community gardens, helping to build more workplace spaces for kids, helping to employ the community members who live in our community in higher wage paying jobs. I don't know about where you guys work. I know when I first came into this system, most of the people that looked like me were making the lowest wages because they were in entry level positions. They had not been allowed the opportunities, right, for training to be able to ascend into other roles. There are very few leaders of color at the table. So the things that I think we can focus on, and particularly in this space, as we're talking about maternal health and infant health, is making sure that not only our women have the knowledge, as you guys were just speaking about, to advocate for themselves, but also know where the resources exist. Because even though the resources are scarce, if you're not aware of even where to go, to get information, it becomes a bit of a challenge. And I think we do our patients a disservice by saying, that they don't want to know or only want to come to get information from us. I think they're hungry for it. Everybody has a smartphone. If we direct them to the places where they can get information, they can help to make better decisions for themselves.
You touched on so many things. I just want to circle back to a couple of those and then ask another question. You mentioned food deserts. There's a term that I've heard now, and it's healthcare deserts. By living in rural areas and the toxins in communities that you spoke about. You talked about advocating for themselves, finding resources, so many things that are important in the Black community. I just want to ask Dr. Echeazu, you have something special that I'd like you to share, if you're okay, with how you are advocating for yourself.
Well, I can share that I am very pregnant. You can't see on the camera, but the belly is there. And this is my third pregnancy, and I would be considered high risk for a couple of reasons. One, because I am Black, because I'm over the age of 35, and I have a history of hypertension. And so I have, already have risk factors there that would immediately increase my risk of having some sort of pregnancy related, morbidity or even mortality. And what I do to advocate for myself is I've gone out of my way to see a Black physician. I drive an hour out of my town and where I live to go and see someone that looks like me. And I'm not saying that any of the physicians that are in my town that I work with aren't capable, but it's just what I feel I'm more comfortable with, because I know that because she looks like me, she's going to pay attention to me, and she's going to listen to what concerns I have, and she's going to take everything that I, talk to her about seriously. And I've always, like I said, we live in a small area, and so the general number of physicians in the nation is already very, very slim. The statistic is that only 5% of all physicians in the entire nation are Black. And then if you take that 5%, only 2% of them are Black women. And so when you have that type of a statistic, it is very difficult sometimes to find that, representation. But I'm willing to drive out of my way to find it. And whether that's, looking online, reaching out, talking to people, getting on social media. A lot of us have social media pages. You just have to be willing to want to look and find, we're out here, but you just have to try to find us. And we can certainly do what we can to make ourselves, present in the community so people know that we're here and can find, can look for someone if you want someone of color. But I think like I said, that's my personal story, but that statistic, like I said, just because I'm a physician doesn't mean that that statistic couldn't still be me. And I'm very aware of that. And so I have to advocate for myself in any way that may be. And that part of that includes going to someone that looks like me. So.
Perfect. You brought up a couple of other things. One is astounding that these issues do cross socioeconomic classes, astounding. And then you brought up the few numbers of availability. So I'd like to I'm going to go back and forth a little bit, but you brought it up and it is important, the small numbers. So Dr. Watson is an emergency room physician. And again, a very rare commodity is the Black male physician. So historically, the emergency room has been used by communities of color as a first line of medical treatment. What issues do you see in the emergency room that reflect some of the issues that we see with problems in maternal and infant mortality and morbidity?
I think it's kind of similar to what we kind of touched on before. one of the biggest, I think, issues is kind of, inherent bias. When people see certain people of certain ethnicity, they kind of come in with a certain, mindset or prejudgment. So I think a lot of times things can be missed or not taken as serious as they should. For me, when I see patients, I think it automatically creates some rapport. Just kind of seeing someone, that looks like you can relate to. It adds a layer of comfort. It kind of decreases some of the skepticism as well. But I do see that, being rare, most places I work, I'm the only Black physician there, or the only Black emergency medicine doctor in that department. So I think, me, I bring a different kind of, perspective. So I'm able to kind of not only help the patients and educate them, but also with staff and kind of, create a balance that otherwise would not be there.
So part of what I'm hearing also is how well we as physicians are listening to our patients. And when I say we as physicians, I mean all physicians across the board. What are some of the things we can do to help our colleagues, and I'm saying non-Black colleagues, do a better job of communicating with patients of color?
So I'll start because as we have been talking about the innate comfort that most of our patients of color have when they see a physician of color walk into the room, and that we listen differently, we take them more seriously, but we're only 5% of physicians across the nation, that we're in trouble if, the 5% is going to have to carry the weight of the disproportionate health outcomes that the 95% have caused. So I think it's important for us to talk about what systems have to do, and not just the healthcare delivery system, but the health education system, right, needs to start there. We need to go back into the medical schools, the nursing schools, the PA schools, and make it mandatory to have cultural competency and cultural sensitivity training the same way it's mandatory for us to do anatomy and everything else. And it needs to be worthwhile training that if you fail it, you can't get your degree. I mean, there needs to be a value placed on competency of providers of health and wellness actually caring for the people that they're taking care of. And that's what we seem to have lost. In a lot of this, we all come into these professions with our lived and learned biases, right? It's just based upon the experiences that we have. So because we're of color doesn't mean we don't have them as well. I think we just tend to have been on the other end of the impact of being treated poorly because of it. So we have a different empathy, and it's hard to teach empathy to people, but I think you have to start with requiring some cultural competency and sensitivity training in medical schools and schools of other healthcare providers. And then at the level of practicing, again, if there are competencies that we're held to in our training programs, in our professional organizations, we will conform. And then if you add on top of that, which is where we're pushing in Louisiana, if you add actual penalties by payers, everybody moves, right? If you don't do X and I'm gonna get docked from Blue Cross Blue Shield or from American or United Healthcare or Centene, then behavior will change, right? So for us, as we look at, every state has the sophistication at this point to be able to at least down to zip codes, be able to look at most of the top 10 healthcare conditions, heart disease, stroke, cancer, right? We report all this data out on CDC. Infant mortality rates, maternal mortality rates, we overlaid that data, right? And you get the deprivation index for those areas, we're saying that providers in those areas who can improve hemoglobin A1Cs, who can improve their low birth rates, they should be incentivized, right? There should be an incentive payment to those providers, and those who suck shouldn't get paid, period. Like, why are we paying for bad care? If you require people to actually report this data, then we should use it to actually move the needle, not just continue to read it over and over again.
You spoke about empathy. And one of the things that I found most appalling about some of this information is that African Americans will express pain and will express a symptomatology that is just not believed by the physicians who are treating them. And so I count pain as an anesthesiologist as a basic need. That is what we all say we're going to do. We're going to alleviate pain and suffering. And so part of this popularization of what is going on in maternal morbidity and mortality came about. I'm sure you probably know the story of Serena Williams when she was pregnant and she didn't feel right. And she couldn't get her physicians, even with her name and her status and her money, she couldn't get physicians to listen to her. So it's a basic need. So I'm just wondering, you gave a couple of examples. What other areas do any of you feel this overflows into? I feel everything, but any other areas that are important as far as this subject matter?
Well, we obviously are talking about infant and maternal mortality in those areas, but I think it is pervasive in all areas. We've seen how the disparities in COVID-19, there's been a heightened awareness, not news to any of us, that these disparities, underlying these disparities were race and racism and systematic racism. But if you look at cancer, cardiovascular disease, diabetes, most preventable diagnoses that are our top 2 to 3 killers of African Americans have underlying race and racism, right? And so I think this is an issue that, no matter the physician's specialty, that physicians of color can speak to seeing colleagues treat patients of color differently, seeing different outcomes, different treatments offered to communities of color. We most definitely advocated as we were an early hotspot with COVID-19. And I told you about our patient population literally calling up to the governor's office saying, I do not have the same resources as the academic medical center, but I have 4 times the number of COVID patients. Am I going to need to call the news? I mean, it's just, those are the ways we're going to need to be more vocal, and that's tough when you are a part of 5% or 2%. Sometimes you're the only person in the room, and there is always the concern, I know amongst me and my colleagues here, for self-preservation, right? If you push and push and push and that's the right thing to do, will there then be no one in the room to actually speak? Because in some ways they'll try to remove you. We're dealing with that right now in our microcosm with a residency director at Tulane, who I don't know if anybody had seen it, been on national news, who was advocating for her residents of color who were being treated differently, given longer work hours. They were not being respected. There was factual information, and then she was demoted, right, out of the position, and is fighting that publicly. So I think there is that tension, as well as we advocate making sure that the systems are there to support us, whether that's National Medical Association, our state medical associations, but that they are out front leading this fight, that we have a collective voice where individuals won't be singled out.
Excellent points. I'm going to touch on that in terms of some of the other areas, but I'd like to bring in, we have Dr. Jeffrey Sterling who has joined us. I'm just going to give a quick bio so everyone knows his expertise. He is a leader in community-based healthcare, organizational operations, and efficiency. His multiple health-based businesses have created solutions in over 36 states and countries. Dr. Sterling is an author of multiple books, and he is a popular healthcare blogger as well. He currently serves as the first Surgeon General of Alpha Phi Alpha Fraternity Incorporated, and he has extensive experience in healthcare industry, healthcare preventive care, businesses, and administration. He holds degrees from the Northwestern University, the Harvard School of Public Health, and the University of Illinois College of Medicine. So welcome, Doctor.
Thank you.
I'd like to add one more thing for discussion that is very important, and that is the aspect of mental health in our communities. I'm wondering if any of you could touch on how mental health affects all of these outcomes and how it may extend into other areas. Dr. Sterling, is that something you're comfortable telling us about?
Sure. I actually have a degree in psychology, so I apply that to the plight of the Black experience at every turn. I think that, we go through so much and we have become accommodating and accustomed to so much. If you're familiar with the concept of learned helplessness and post-traumatic stress, it very much is applicable to the African-American community. We simply have so much more put upon us than other communities, and we are so willing, unfortunately, to put up with so much more than others have to. When it comes to health, that means that we live in perpetual conditions of comorbidities and healthcare disparities and medical, pharmaceutical, and food islands. It's a situation that when something like COVID comes along, it's only a stressor that reveals the native situation in which we live. So it is folly to try to create solutions to, it's kind of like whack-a-mole, where you try to dig out of a situation such as COVID when in fact the fix is already in because of the conditions in which we find ourselves. If you want to apply mental health solutions to what it is we have to deal with, you really have to look at co-determinants of health. There are things like financial success and access to education. There's so many things that are fundamental to our plight that in order for us to actually get a clean slate and to have some degree of mental freedom, we really have to, as a community, go back, take several steps back, and fundamentally define what it means to be Black, what it means to be successful, what it means to be health. And one of the things that I constantly talk about is we as a community need to value health at a higher level than we do, and to learn how to become empowered and better stewards of our own healthcare, because quiet as it's kept, the cavalry is not coming around to save us. We really have to learn how to do what it is we can for self, and that sense of empowerment ultimately is what's going to give us a stronger capacity, a stronger mental framework, both individually as a community, so that we can attack these things. So simply put, we have to learn how to stay ready so we don't have to get ready when these types of crises occur. You're on mute, Jocelyn.
This sounds like, thank you. This sounds like you're talking a little bit about preventive care, which again, in the Black community is something of an issue. So preventive care in terms of pregnant patients, preventive care in our children, how to decrease infant mortality. We brought up hypertension. We've talked about cardiovascular disease. We've talked about difficulty with patients getting medicines and taking those medicines because of economic problems. What can we do? And is this more than just education, or is this a policy problem that we need to address?
I don't know if you're addressing that to me, but that actually is right in my wheelhouse. Actually, one of the things that I do now, a lot of my work is with SIMCO, which is America's first managed preventive health organization, and we're doing work around the world. We're actually having a conversation with Kenya in terms of implementing their national healthcare program, and we are actually tasked with putting in place the health prevention and health promotion components of their universal healthcare plan. Simply put, in the United States, we don't have a healthcare system, we have a healthcare industry, the purpose of which is to generate commerce, and healthcare outcomes are an offshoot of the generation of commerce. And what that means practically for us is that we're in the business of sick care. We don't do health prevention and health promotion very well. It's always been true that an ounce of prevention is worth a pound of cure. So for those of us, and again, this is through no fault of our own, but it's also the fact that even if it's not our fault, it's our responsibility. We have to learn that the emergency department, even though we may have financial limitations, cannot be our portal of entry into healthcare. We have to learn how to deal with circumstances way before illness ever comes into the conversation. You know, we only see physicians once or twice a year for those normal checkups. So we have to develop the mindset. What exactly is it that we should be doing those other 363 days out of the year? And that's health prevention. You know, as a community, we have to learn that the things that we talk about, thickness and loving big bone and all these other things, well, that's physically and visually attractive, but it doesn't translate into health. I always tell people that, you know, that is a judgment, but obesity is a medical fact. And the truth of the matter is that we can be our worst enemy. But as a community, we really have to learn and promote basic considerations: stress reduction, diet, exercise. And if you can't exercise, you need to learn how to appreciate that activity is just as good as exercise in many parts of the world. So yes, we have to get in the business of health prevention because we actually are in a position where we can control those things much better. And everything that we do on the prevention side puts us in a better position so that when a disease like COVID comes on board, we actually are buttressed and we're steeled to better deal with those diseases that are trying to kill us. So once again, if you've stayed ready on the front end, you're going to do better on the back end. So that's a conversation that's very in depth, but there's some real fundamental and basic tenets. You know, diet is 75% of the game. And if we get away from the sugar and the salt and just migrate more toward a plant-based diet, so much of this would take care of itself on its own. But, you know, it's a very simple concept for people to really do one less fat thing and to really move toward things that translate into better health and better healthcare outcomes, and both a quality of life and a longevity of life that would be even better for us.
Excellent. Also, in terms of, we talked a little bit about the education of residents, of nurses, and of people of color coming into our healthcare field. What can we do, if anything, to increase that high school to college to medical school pipeline and beyond? That's where I'm hoping there's some promise for the future in terms of increasing our number, as well as educating non-Black physicians. What ideas do any of you have about how we can do that?
Well, there has to be an intentionality about exposing communities of color to these professions, more than just having on career day physicians of color to come in and speak, right? There have to be STEM programs and resources put into schools to make sure that our students who live in potentially under-resourced areas that have poor educational systems, like we do here in New Orleans in the public school system, that they have access to the same science, technology, engineering resources that those in private schools do, because right now that's not the case. And so they're at a deficit right out of the gate. And then they don't have the same opportunities to go into internship, volunteer programs, learn what it means to be in one of these STEM professions, to get excited about it early on, right? So we partner locally with STEM NOLA, which is a local program that's been in place here for many years, and they take high elementary through high school students and do STEM programs on Saturday for free to parents because organizations like ours pay for them, right? But you've got to invest in that. Again, going back to healthcare systems in this healthcare industry, as Dr. Sterling talked about, have to get involved and invested in well care way upstream, which is not what hospitals normally do because we get paid to take care of people who are sick, right? Again, if there is a change in the way in which the value is placed by our payers on prevention and we're evaluated as providers on how well we do with it, that will change behavior. So I do think policy matters. I'll use an example from pediatrics, right? So in pediatrics, we see a lot of policies that have been put into place to require parents to get kids vaccinated or else you can't go to school. To require parents, right, to bring their kids in for certain visits or you can't go to school, right? But those are preventative visits. It's a preventative measures that have eradicated diseases that were once killing millions of people. So it can be done from a policy perspective to change behavior. We've seen it, while not perfectly work in pediatrics, we've seen it work very well around childhood vaccinations and eradicating disease because we created policies and also made it free, right? So the Vaccine for Children's program provides it, so providers give it. There's not a barrier to payment. So all of these barriers to access that we experience along this trajectory of health, whether it's being able to actually find a location, get the right treatment, pay for the right treatment, those things can be removed via policy, but there has to be intentional incentives put towards it.
Well, now
Could I
you've brought up
applaud that?
policy. Oh,
No,
sure, Dr.
Yeah,
Dr. Sterling.
I just want to applaud the first part of what you said. Intentionality is everything. You know, I actually became a physician because my mother was smart enough to tell me that Martin Luther King was a doctor. I share a birthday with him, but that's a different conversation. And it wasn't until I found a love for medicine on my own that I figured out he wasn't actually a physician. You know, the point to be made here is very simple. There's public health data that says that FUBU is real when it comes to health. There are better healthcare outcomes produced in our communities when the deliverers of healthcare are culturally sensitive and culturally specific, in other words, Black. To that end, intentionality at the beginning of the conversation, sending kids into STEM programs is an absolute must. We have to align our values so that people can have aspirations toward becoming all of the things that are involved in the healthcare specialties, not just a physician, but nurses and hospital administrators and owners of various considerations. One thing that you probably don't know is that to that end, back in 1989, I actually founded an entity called MAPS. Many of you are familiar with it, Minority Association of Pre-Health Students. These organizations have chapters on 300 college campuses around the country, and it's through the Student National Medical Association organization of which I was chair for 3 terms, and that smooths the path. So intentionality coupled with the assistance that's necessary to help people cross that bridge is absolutely what's necessary. You know, we're in a situation now where, you know, Black males are actually only 3% of the physician pool across the country. That cannot stand, that is not acceptable. We have to get in people's faces. And once again, the operative word is intentionality. We have to attack this because if we don't take the initiative and make this happen on our own, then it simply is not. It is a crisis, it is critical, it is going to produce healthcare outcomes on the back end. So I'm glad you brought that up, but we really have to do something about this because we're just being overrun in terms of all of the complaints that occur today in terms of infant mortality and insensitivity of the medical and research communities toward Blacks. Well, so much of that could be abated if we were the individuals that were doing the research and providing the healthcare. So I really do appreciate your bringing that up, but we have to be intentional, to coin that phrase again, in getting people to seek out professions in the health sciences.
I'm curious, we do have 2 Black physicians, male physicians on our panel. Dr. Watson, what got you interested in the medical field?
So for me, I kind of started off kind of early. I'm the first physician in my family. I did kind of have a love for science. I had a love for treating people. I want to kind of take care of people. That kind of attracted me to the field of medicine in general. And as I was looking at different fields, emergency medicine was the one that kind of caught my eye, just because you got a variety of everything, you get to see everything, and you kind of get immediate access to assess, treat, and kind of heal and stabilize patients. But for me, I look at my family, and being the first creates a precedence. So I have a nephew and a niece who now want to be physicians. Okay, and I think seeing me creates that, that love, that passion, and we'll go that route. And I think that's the biggest thing in our community, is not having enough of us to see that could be a realization, to see this is what a Black doctor looks like, this is what I can be, and this is the impact I can have. So I think starting out for us, if we reach back, showing others, younger and future generations, that you can be a doctor and more, this is what it looks like. It's not something unattainable, and you can see it and then you can realize it. So I think as an attending, reaching back to residents, who subsequently reach back to medical students, who reach back to graduate students and undergraduate students, down to high school and elementary school, down to preschool, that we can create this network that starts at an early age and keep it active.
Excellent. So it sounds like we've touched on kind of the ground level things, the intentionality. We've talked about a lot of the social determinants of health. I just want to, as we're coming to a close here, Dr. Davis, you brought up policy, and I have to talk about, or ask you to give me your impressions about the role of voting rights in all of these social determinants of health, and what responsibility we as citizens have in ensuring that voting rights is maintained, our democracy is maintained, and as it pertains to the social determinants of health.
Well, it's vital. The policy makers we elect, right? Those policy makers are supposed to be carrying our voices, our needs, our desires forward. Without having equitable voting rights across the US, then our voices are being muted, right? So we don't have the ability then to elect those who we feel will empathize with us, who will be intentional about impacting the social determinants of health, whether it's in the workforce development, economic development realm, education, social justice, criminal justice, whatever area it is that we're working on policy for. If we don't elect or have the ability to elect individuals who have our best interests in mind, then we're never going to get to the policy changes that are necessary to help improve this system that has been historically racist and systematically providing disparate care to people of color, as we've discussed. So I think voting rights are integral and vital to what we're discussing today. We have to be as intentional about being out front and advocating for equal access to voting rights for all people, and advocating against laws that tend to strip them away, and reminding everyone how important it is for all of us to participate in this process. I think sometimes as people of color, if there is not a particular person that motivates us, excites us, or something controversial on the ballot, that we don't exercise our right to vote. Every election gives us the opportunity to have our voices heard, and we should never become complacent to that.
So true. Well, our time is coming to a close, but I would love to give each of you, if you would like to have any final words, and your experiences have been simply amazing. So if any of you would like to give just kind of a closing on what your perspective has been on the effects social determinants of health on healthcare.
I think guess we can go around in the circle, but I think for me, I just, I mentioned it earlier, and, there's so many different things that we've touched on that really need to be addressed to, make any change in this topic. But starting from just each individual patient, where you can start, the beginning is just one of the first biggest things is education. And that is you have to want, just like you talked about being intentional, patients have to be intentional about wanting to take care of their health, wanting to know as much as they can to be able to advocate for themselves. I know some people don't have those resources or those, they don't have that opportunity there for them. But if we try, that's the best that we can do, is make an effort. And that's, educating yourself as much as you can about your health, asking questions when you do go to see your doctor. Don't just, let them spit all these things out and then you just walk away. Ask questions about, the tests that they ran. Ask questions about, what screening do I need? These are things that, the other 95% of physicians might not focus on with people that look like us. And so advocating for yourself is being able to, it's unfortunate, but you might have to ask, oh, is it time for me to be screened for colon cancer? Is it, how often do I need to have pap smears? How often should I have my mammogram? These are things that if we focus on those, then we're going back to that prevention part that, Dr. Davis and Dr. Sterling talked about earlier. And so I think just educating yourself as best as you can. Us as physicians, we have to do our part to also educate our patients about resources, and taking that extra time to focus and talk about things like exercise and cardiovascular health, because we might be the only person that says anything to that person about it. I've certainly had patients that didn't think twice about anything until I had a real sit down, come to Jesus conversation with them. And I know that it worked, because the next time, I followed up with them. I didn't say, okay, see you next year, but we followed up in 3 months and we say, this is our action plan. And we're going to truly focus on this. And they've come back and said, thank you. I wouldn't have done anything if you had not really pushed me to really focus on myself, because we have so many other stressors and things that we focus on. And, I talk about moms in general because I take care of mostly women, but we focus on our children, we focus on our families, and we don't worry about ourselves. And I have to constantly remind moms that you can't take care of anyone if you don't take care of yourself. If you're not here and if you don't take care of your health, you're not going to be here to take care of the babies that you're, so concerned about. So you have to find the time for carve out that time to make health a priority. And so, that's the biggest thing, is just educating and making health, making it your priority, because most people don't, because they're so focused on so many other things that we have to, unfortunately, but we have to try to do the best that we can and focusing on that.
So true.
And just kind of, piggybacking on that, knowledge is power. Education is key to knowledge. And as we try to inform our patients and educate them, we only do one at a time. So having community outreach programs, whether it's through local community churches or programs and organizations, we can outreach and teach more and let people know that you do have some power and you do have some control. And the more knowledge and information you have, the better off you are. And prevention is key. And prevention has to be intentional. Like most of our communities, you see a lot of liquor stores, you see a lot of fast food. It's not easy access to eat healthy. It's not easy access to get things that you need. And that is intentional. So you have to make a conscientious decision. You have to work a little bit harder to be healthy, to be informed, to take your health into your own hands, and, try to get that prevention that you need so that you don't get critically ill and have all these chronic illness such as high blood pressure and diabetes and stage 4 cancer and things of that nature. So I think for us, the best route will be knowledge and information, getting it out there to our communities and kind of letting them know you have to, take this on and be, hands-on as well.
So true. Dr. Davis?
Yes, so I'll take it just one step further. if not maybe a few. I totally agree with knowledge is power, and there can't be too much or over education to our communities, and re-education about what we should be doing to keep ourselves well and moving towards our best attainable health. However, no level of individual education is going to systematically dismantle the lack of access that our communities have to opportunities for wellness. So I think we absolutely have to lead the charge in educating our patients on what they should be doing and advocating for themselves, but that as leaders in our community, that we have to advocate for those who can't advocate in some of the spaces where it's necessary, and advocate for those changes in the built environment that you guys referenced with respect to the policies and the zoning laws that allow for dollar stores and liquor stores, you know, across the street from each other in our communities, but are zoned out in more wealthy communities. That those are things that we can help to bring more light to and help to advocate against. That we also look at where are the opportunities for us to ease some of the barriers to the educational attainment that we push our patients to, right? So how can we bring farmers markets into food deserts? How can we bring physical activity opportunities, biking paths into communities that don't have public parks or well-lit parks? So for us to start to think about, even in our small ways, how can we help to ease those barriers to health? You know, I would have patients all the time tell me, you know, when they come in, we as pediatricians, you know, we're putting everybody on that growth curve and then showing them how far above the curve their kid is, and telling them how they should be more physically active. And I had a patient to come in and tell me that, you know, she would keep her son inside playing video games because it's safe, right? It's safer for me. So then we have to think about, then what should I be telling you about physical activity inside of your safe home, instead of saying you need to go and walk or ride a bike, etc. Because if you feel like your child's life might be lost, he's not going outside, right? So I think we have to start thinking about how we can ease those barriers to health and wellness, which may be a little bit different for our patients, but it'll be so much more meaningful and attainable for them.
Dr. Sterling.
You know, I run a global healthcare consulting and implementation company. The word there is implementation. Anybody who sits around a water cooler knows what to do theoretically, but getting it done really is where the outcomes are produced. I just want to speak to everyone listening that you need to move with purpose. You have to be, forget social determinants for a second, figuratively speaking, it's a real thing, social influence, social determinants. How about we become our own influencers? How about we become more empowered? How about we become the stewards of our own healthcare delivery? I'm not talking about disease, I'm talking health. Everybody can do one less bad thing. Everyone can actually learn. Everyone can take steps to reduce their stress. It's just a matter of getting it there. Now, again, if you are a highfalutin physician like us on the panel here, you can go in a straight line. But believe me, if you are intentional and directed and focused, you can actually offset some of the negative social influences and determinants of health. You have to get to the point to where you decide that you want better, okay? You have to know better, then you have to do better, and then you'll be better. The name of the game here is health promotion. You have to make a commitment. You have to value it in your life. You have to value it in your family. You have to value it in your community. So many people talk about things that run in their families. And the diabetes example is something that people really should think about. Very often, people don't have diabetes because it runs in their families. You have diabetes because your bad dietary habits exist in your families and everyone eats the same bad things. that's the type of thing that's very amenable to very simple changes. And if you and your family actually were to come together and have a pretty fundamental and simple conversation about what we can do to be better, it actually makes a difference. Just like every measure of activity improves your cardiovascular health, you don't have to go buy a Peloton and go crazy. Every little bit actually makes a difference. It is the same thing with health promotion. Today, make a determination about what you can do to improve your level of health. And it's just like a ripple effect. You throw a pebble in the water, it makes a difference, it matters. You just have to be intentional, you have to be focused and persistent, and you can't do it by yourself. Get the people that are around you to care about it as well, because you're only going to see me, and by the way, Dr. Watson, in an emergency department at the beginning of your course of sickness. That's not where you want to meet me. So just think about that and just take this for what it's worth, because disease is an entirely different conversation. It's going to be there. Just like I tell kids all the time, success is learning how to do what you're going to need to do eventually. We always talk about people that beat cancer and come back from the diseases. Well, how about we learn to prevent those things at the beginning of the conversation? That's where the real gold is. So that's the message. I want you to be empowered. I want you to be focused, and I want you to be better stewards of your health. And you can do this. We all need to be the message. And as such, we can do better. So I wish everyone the best of luck in their endeavors, and we all are certainly here to help in the ways in which we can.
Well, I can only hope our listeners have learned as much as I have today and can feel as empowered as I'm leaving this session today. I want to thank all of you for your contributions, Dr. Watson, Dr. Echeazu, and Dr. Sterling. Thank you. And Dr. Davis, thank you so much for your time. Thank you for sharing your experiences and your vast knowledge. I appreciate all of you. We actually probably need to do a series on all of this, but for now, thank you so much. I appreciate you. Bye-bye.
Thank you.
Bye-bye.
Yeah.